Hello, everybody. This is Alan Heckman from EMS Education Solutions, and we're going to be talking about behavioral emergencies for the emergency medical responder. Let's get started. The emergency medical responder will not only be taking care of patients from a medical point of view, but they'll also be taking care of patients from a psychological point of view. There are many factors that influence behavioral changes in our patients. Some of them could be medical conditions, such as low blood sugar, causing a patient to act abnormal, physical trauma, such as trauma to the head, underlying psychiatric illnesses that are contributing to the way the patient is acting when we're taking care of them, mind-altering substances. There's a bunch of drugs out there, and patients can respond to it in a variety of different ways, and just situational stresses, the death of a loved one, just experiencing some type of a traumatic incident will have a huge effect on a patient's behavior. Just like any other patient that we approach, the primary assessment for behavioral emergencies remains the same. We will arrive on the scene and perform a scene size-up. Is the scene safe? Do I need additional resources? How many patients do I have? Does this appear to be a medical or a traumatic issue? And once we're able to resolve all those issues and make sure we're taking body substance isolation, we move on to our primary assessment, airway, breathing, circulation. Are there any identifiable threats to life? If so, they get corrected here. From there, we'll move on to our history. We'll obtain that sample history that you learned about. We'll perform a secondary examination that includes vital signs and a head-to-toe exam, and then we'll reassess our interventions on the patient to see how they're doing. When performing a scene size-up on a patient experiencing a behavioral emergency, you're going to want to take extra caution. You never know what kind of a situation you're going into. For instance, you might be responding to the scene of someone who is acutely suicidal, or you might be responding to the scene of a domestic incident. In these situations, you need to understand just how dangerous it can be for you as an EMR and take the precautions necessary to make sure you don't become a victim yourself. If the patient is oriented and responsive, well, then you've basically completed your primary assessment. Because if they're oriented and they're responsive, then you know they've got an airway, they're breathing, and they've got a pulse. Get a good history on the patient to include the sample format. Here, a past medical history and current medications are going to be really helpful to you as it pertains to the behavioral emergency patient. The secondary survey should be used to rule out any obvious injuries and focus on the signs of medical illness. Remember, there are many medical illnesses that can contribute or cause a patient to appear like they're having a psychiatric problem when in reality it's a medical problem that's causing the patient to act that way. So make sure you do a thorough examination to rule out any underlying medical issues. Remember that we're going to reassess our patients every 15 minutes if they're stable and every 5 minutes if they're unstable. If you can't complete the assessment, then document the reasons that you weren't able to complete it. For instance, if you spent your entire time managing an airway, well, then you weren't able to perform the rest of the examination. And that's perfectly fine, just as long as you document it. A behavioral emergency is basically a situation in which a patient is exhibiting abnormal behavior. And that's a relative term because what defines normal behavior? It really comes down to what we have accepted in our society as the normal, typical behavior. And when somebody acts outside of that realm, we deem it to be a behavioral crisis or a behavioral emergency. One thing I will caution you to understand is cultural differences. And this is where talking to bystanders and family is going to be so helpful to you. Sometimes the way a patient is acting is acceptable in their culture. And if it's accepted in that culture, even though it might appear to be abnormal to you and me, it is not considered to be a behavioral issue. Don't forget to check for those underlying medical conditions like diabetes or respiratory issues, like if a patient's hypoxic or they've had something affecting their central nervous system like a stroke, because all of those can cause a patient to act abnormal as well. Other medical conditions like head injuries, high fevers, infections, or really low body temperature can cause a patient to act abnormal. On your physical assessment, you can look for things like head injuries or injuries that would result in shock and cause inadequate tissue perfusion to the brain. Psychiatric illnesses that can cause a behavioral crisis could include things like depression, a panic attack, or psychotic behavior. Um, Depression and panic make sense to most people, but what is psychotic behavior? Psychotic behavior involves a patient that is exhibiting things that we would not deem to be normal. These would be things like hallucinations, whether they be auditory, meaning they're hearing things, or visual, that they're seeing things, or if the patient is delusional, meaning they're making claims like the patient's telling you they're Jesus Christ or something like that. That is a delusion. Delusions and hallucinations together equal psychotic behavior. You could be encountering patients, as I said before, on drugs or alcohol. And those can cause a behavioral crisis in patients depending on the substance that they've taken or a combination of substances that they've taken. Situational stresses can result in a behavioral crisis. For instance, the death of a loved one. You may respond to the scene of a person who subsequently died, and while you're not necessarily caring for the deceased person anymore, you may be providing care for that family. And depending on how traumatic the death was, I've personally have been on EMS calls where we've transported members of the family to the hospital because of how emotionally distressed they were. So as I said in the last time, patients may go through some type of a situational crisis. What is that? Well, it's a state of emotional upset or turmoil. It's generally rapid onset, it's unexpected, and it completely disrupts what's normal for you at that moment in time. It's so disruptive and it's so disturbing that your underlying coping mechanisms cannot handle it. It's something that just hits you out of the blue, and emotionally you're a wreck and you're unable to just deal with the situation. The good thing is that this typically only lasts a short time, but it can cause what we would refer to as some socially unacceptable, self-destructive, or dangerous behaviors. Um, for instance, someone that becomes acutely suicidal after witnessing a traumatic event. Or someone gets fired from a job and they immediately want to go threaten somebody or threaten their own life. These are all things that are not socially acceptable, and it is a direct response from this sudden change that your body and your brain was not expecting to happen. There are 4 emotional phases to each situational crisis, and we're going to break them down for you in the next couple slides. People may not experience every phase, but they will experience at least one or more of them. All right, so here's one of the phases. High anxiety or just emotional shock. High anxiety is characterized by a flushed face, rapid breathing, rapid speech, increased activity, a loud or screaming voice, and general agitation. We've all been around somebody who's been extremely stressed, so you should be relatively familiar to recognize when someone's extremely anxious or extremely stressed out. And this hits them suddenly or within a few minutes after experiencing that emotional trauma that we talked about before. So this emotional shock is often the result of a sudden illness, an accident, or the sudden death of a loved one. It's typically characterized by cool, clammy skin, a rapid, weak pulse, vomiting and nausea, or just general inactivity or weakness. Now, this is a little bit different than the high anxiety we talked about on the previous slide. This is the emotional shock. All right? So before we had a patient that was rapid, kind of sweaty, and angered, and all that kind of stuff. Here we're seeing a little bit the opposite. They got cool, clammy skin. They may get sick, and they have just general inactivity and weakness, as if they become very withdrawn. Denial is very common. It's common following a traumatic incident. It's common following a death. It is the refusal to accept the fact that the event has occurred. People just deny it. They don't believe that it even occurred. Your response should be that you allow the patient to express their denial. Don't challenge them. Don't throw it in their face. Just listen to them. Do not argue with them, and try to understand the emotional and psychological trauma that the patient is experiencing. That's called empathy. Sympathy means that you've experienced it before. Empathy means that you're at least trying to put yourself in their shoes. We're not there to judge them, and we're not psychiatrists. Our job is to just listen and offer support. Anger is a very normal behavioral response following an emotional situation. It may follow denial, or it may even replace denial. People may vent anger feelings at you. Just be careful, because their anger may get to the point where it becomes physical. So always take your scene safety into consideration. Never allow yourself to be in a situation where you don't have an exit. So if you're in a room and there's only one exit out, you should be closest to that exit. If the patient gets between you and the exit, you have blocked your safe access out of that room. So always keep that in consideration. Frustration and a sense of helplessness can often build to anger. Remember, your job is to remain professional and calm and be a good listener for the patient. Remorse or grief typically comes a little bit later. You tend to have experienced maybe the denial and the anger stages first before you're going to hit remorse or grief. But it's basically the acceptance of the situation, and now you're starting to experience the grief or the tragic emotions that go along with that. All right, so what's your role when dealing with this behavioral crisis? Well, first and foremost, you want to follow the steps of the patient assessment sequence, always starting with the scene size up and your scene safety. After the primary assessment, you may need to obtain a patient's medical history or perform an exam. I think that that's an important thing to do. A, you'd want to rule out medical causes for them to act that way, and B, a medical history and a medication list can really help you understand what's going on with this patient. Perhaps they have a history of psychological issues, and so now it starts to make sense for you why they're acting the way they are. Your most important assessment skill may be your ability to communicate with the patient. Your job is to ask open-ended questions and allow the patient to just talk. In this situation, it's more important to let the patient vent than it is to probe for a significant amount of information. When you're going to communicate with a patient who's experiencing a behavioral health issue, make sure that you are putting yourself in a position in which you're able to communicate with them. Unfortunately, a lot of times first responders tend to be police officers, and so when patients see the uniform and the badge, they immediately assume sometimes that they're in trouble. You need to get yourself into a position that shows that you're not threatening and that you're there to talk with them. So when you approach them, introduce yourself, ask them their name and what you can do to help them. Be honest, warm, caring, and empathetic. Your job at that point is to just take care of their emotional needs and not be an authoritative figure. Be really aware of your position and your body language. Standing over top of the patient like this guy is here takes a very authoritative approach, and this patient may shut down and not want to talk to you at all. This is a much better position to have a conversation with your patient. Squatting down and you're at eye level. This shows the patient that you're ready to listen to them. So get down at their level and establish eye contact with them. Use a calm, steady voice and provide honest reassurance, but don't provide false hope. Try not to let negative personal feelings interfere with your attempt to provide assistance. After a while, your life experience may or may not be helpful in the situation. You may not agree with what the patient's experiencing, or you may not agree with their emotional response. Once again, it's not our job to judge. It's our job to take care of the patient. Simple acts of kindness can provide comfort and reassurance. in a difficult situation, perhaps in a death, it may be a good gesture for you to offer to call their clergy or their minister to have them respond to see if they might be able to provide help as well. I've been on scene sometimes where while we're waiting for the coroner to show up, we've made a pot of coffee for the family, just doing whatever we can to help provide some support for them. After the patient's had an opportunity to talk, you want to demonstrate some active listening skills back to the patient. So you're going to use things like restatements. Basically, you're going to rephrase in the person's own words their thoughts and kind of repeat it back to them. This shows the patient that you've taken an active interest in what they're saying and that you're listening to them. You can say things like, "So I understand when you say this, you mean this," or I'm hearing a lot of this. When you're rephrasing those things back to the patient, it shows that you're actively listening. As I said before, be honest with them, but do not give false hope. Do not say things like, "Everything's going to be okay." You don't know that. You don't know that everything's going to be okay. So just offer support. Redirection. Sometimes patients get so off track because their emotions are just leading them down so many different paths that it's really hard for you to understand the story. So sometimes you have to redirect the patient and bring them back to the original question that you asked. Or if they're giving you a whole bunch of information, just say, "I'm having a little trouble following you. Let's go back to the beginning and go through this again." That will help you organize your thoughts appropriately, and it will help keep the patient on task. You can also use redirection to help alleviate a patient's expressed concerns. And if you're really having difficulty understanding them or getting the whole picture, maybe you need to move the patient to a quiet, more private location where you can have a much thorough conversation. We mentioned empathy before, and that's basically imagining yourself in another person's situation and kind of sharing his or her feelings or ideas. We don't know what that person's going through right now. Maybe you've experienced the death of a loved one before or some type of similar trauma. That's fine, but there's a lot of situations that you may not have gone through and you just don't understand. So we do our best to put ourselves in the patient's shoes or the family member's shoes and try and respond appropriately. With regards to empathy, it is indeed one of the most helpful concepts that you can use. But it's not something that you can learn about in a book, unfortunately. It's something that you just have to develop over time. Empathy is something that hopefully your parents taught you, and that was to keep an open mind, listen to what people have to say, and consider what it must be like to go through what they're going through at that moment. When you're communicating with them, make sure you identify yourself and let the patient know you are there to help. As I said before, body language is going to be everything. Be careful about how you approach them because they may deem you as the enemy and they're not going to want to talk to you. Ask questions in a calm, reassuring voice. Allow the patient to tell you what happened. Don't be judgmental. Just say what happened. Let them tell a story. Ask little questions. You want them to do most of the talking, and try not to interrupt them. Show that you're listening by using restatement and redirection like we talked about on the previous slides. Do your best to acknowledge the patient's feelings. You don't have to go crazy with it. You can just say, "I'm sorry for your loss," or "This must be very tough for you." Just acknowledge that you recognize that they are upset. And always assess the patient's mental status to make sure that there's not an underlying medical issue that could be causing this behavioral crisis. Here's something that's great for an EMR, particularly if you are law enforcement or even firefighting. Performing crowd control can certainly reduce a patient's anxiety when there's just too many people around. Imagine being the parent brought to the scene of a car accident where you're going to find your dead teenager child sitting there. And there's about 100 people standing around watching this scene. It's a very emotional situation to go through, and the last thing that that family member needs is to be standing there with 100 people around watching. This is a great opportunity for law enforcement and even firefighter personnel to help clear out that area, to give that patient and that family member some privacy and some dignity. So during your scene size up, you want to determine if there's a crowd that might need to be controlled, or they might even become hostile. If that's the case, during your scene size up, when you go through that, do I need additional resources? This would be the time to say, I'm going to need law enforcement here to help control this crowd. Domestic violence situations is another behavioral health type of EMS call you might be involved in. It's pretty common in today's society, and it takes multiple different forms. It could be from elder abuse and neglect, child abuse and neglect, or even spouse partner abuse. That's a real problem, especially this one right here. Believe it or not, an EMS or a law enforcement or firefighter is more often to be shot, stabbed, or just physically hurt when dealing with one of these situations than most any other call that you're going to go on. Emotions are high in these situations and dangerous things happen. So when you're responding to a domestic call, make sure that you are maintaining safety for all the rescuers as well as you. You come first, your partners come second, and the patient comes third. If the scene is not safe, get out of there until it can be secured and you're told it's safe for you to go in and take care of somebody. Once you know that that scene is secure, you're going to conduct an effective assessment and provide any medical care that's necessary for that patient. And you want to understand the requirements for reporting abuse in your state. We'll talk more about this in later on in pediatrics, but you in Pennsylvania are deemed a mandatory reporter of suspected abuse and neglect. You don't have to confirm it. You certainly don't have to investigate it. Your job is to merely report it if you suspect it. Right now in Pennsylvania, if you fail to report, you're going to be subject to all kinds of legal issues. So if you think something's going on, report it. Signs of physical abuse would be things like broken bones that don't make sense to you. For instance, the femur, the longest bone in the body. Someone says, well, they fell out of a chair, and they broke their femur. That doesn't make sense. Femur fractures, you see those in high-velocity car accidents, not from falling out of a chair. So if they told you that story, you should suspect abuse. Cuts in places where you just weren't expecting a cut to happen, like stab wounds to the abdomen. Those are not accidents. Typically, that was either self-inflicted from a behavioral health issue or there was a domestic issue and somebody got stabbed. So take those things into consideration. Other signs and symptoms that domestic violence may have occurred. Look for things like head injuries, bruises, burns, scars from old injuries that kind of indicate a pattern of frequent traumatic events for a patient. Injuries in various stages of healing. You may note some bruises on the body that are fresh in some areas, but look old in other areas. A fresh bruise will have that ecchymosis appearance. Ecchymosis is the fancy medical term for black and blue. As that black and blue mark kind of gets old, it turns to a yellowish brown. And so if you're seeing wounds all over the body in multiple stages of healing, that would be a sign of abuse. In addition, internal injuries that don't make sense. Patient falls out of a chair again, has internal bleeding. That really doesn't make sense. So we have to keep those things in mind when we're considering domestic violence. In addition to the physical symptoms that go along with domestic violence, you should also be paying attention for some of the emotional symptoms that patients might exhibit. Things like depression, history of suicide attempts, abuse of alcohol or drugs, or feelings of anxiety, distress, or hopelessness. Abusers themselves may be paranoid or overly sensitive, obsessive, or even threatening. So basically, any behavior that's out of the ordinary for the situation should potentially be a clue for you that something else might be wrong or strained in the relationship between the people when you're at the scene. Always be careful to monitor for scene safety. With regards to safety, Try and separate the patient from the abuser if it's feasible. Try to keep from judging the patient. We don't know the details. Our job is not to judge, it's to take care of the patient. Having the presence of law enforcement personnel may be helpful for multiple things. One, it can potentially remove the patient from the abuser, and two, it provides added protection for you as an EMS provider. In your state, you should be familiar with knowing what the rules are for reporting suspected domestic violence. Right now in Pennsylvania, EMS providers are not mandatory reporters for this. However, it should not stop you from reporting something if you feel concerned. Domestic violence and abuse goes through a series of phases. There is the tension phase, where the abuser becomes angry and often blames the victim. There's the explosive phase, where the abuser becomes enraged and loses control as well as the ability to think clearly. And then there is the makeup phase, where the abuser makes promises which are seldom kept. This is a vicious cycle that keeps repeating itself over and over again. Obviously, the dangerous portion here is going to be the explosive phase, particularly in an area where the abuser is not thinking clearly. This is where murder-suicides take place, as well as a whole bunch of other violence. You always need to take that into consideration when responding to a domestic scene to make sure you're being safe. A lot of times in EMS, we encounter patients that can be violent. There's multiple reasons why they could be violent. Sometimes they're for an underlying medical reason, like low blood sugar, or maybe they suffered a head injury. Sometimes it is at the scene of a domestic. So you just need to be careful. When you're with one of these violent patients, do your best to immediately attempt to establish verbal and eye contact with the patient. Never lose sight of the patient. Always keep your eye on the patient. Check with family and friends about the patient's history to see if they have got a past history of violence. Look for signs of potential violence, such as a history of violence, yelling or verbal threatening, loud, obscene, or bizarre speech, pacing, inability to sit still, and protection of personal space, and history of abuse of drugs or alcohol. Um, Always be aware of their body language. Sometimes they lead with their head, watch what their arms are doing. You should always keep a good distance between you and the person. And as I stated before, never block your exit and never let the potential violent person get between you and the exit. Always have your back to the exit so you can step out quickly if you need to. You never want to force a potentially violent patient into a corner because they may become extremely violent and come out swinging at you. And as I mentioned before, don't allow yourself to be cut off from the route so that you can retreat if you had to, if the situation got worse. Communication with a violent person should be limited, probably to about usually one person. If you and your partner are trying to talk to the patient, it can actually cause some increased stress. So really, it should be the rescuer with whom the patient seems to have the best initial rapport with. So you do the best that you can, and then if you're the communicator, you explain to them, my partner needs to take your blood pressure and that kind of stuff. But the more of a rapport you can establish them, hopefully the better the situation is. Obviously, law enforcement is always appropriate to have, but sometimes that can escalate a situation too. So every situation is different. You just got to use your best judgment and experience to help guide you through those situations. Violence against EMRs, boy, we are definitely in the business of being targets sometimes. So we always have to be careful, even at the simplest scenes. Sometimes can turn violent. So always be vigilant for something to change quickly. Um, Factors that increase the risk of violence in the workplace would be working alone or in small numbers. Like in EMS, we typically just work with one other person, and if you showed up and there was 5 people there, well, you're immediately outnumbered. Working late at night or early in the morning, working in high crime scene areas, and working in community settings. Basically, all the environments in which we work in increase our risk of violence. Always be vigilant when responding to scenes where there's the potential for violence to take place. Things like crime scenes or incidents involving gangs, large gatherings where there's hostile people, or domestic disputes. Generally, if you're responding to any one of those scenes, you should have law enforcement responding with you, and let them enter first, let them secure the scene, and then they'll call you on the radio and say the scene is secure, the scene is safe for you to enter. So just some precautions here to help protect you from violence at a scene would be to take steps to keep yourself and other rescuers safe. So always be aware of your surroundings. Ask yourself, geez, is this scene safe? Do I need other resources here like law enforcement? And have a plan before you go in. As I said before, always keep an escape route between you and the patient. Um, from a prevention point of view, the best way to avoid violence is to not be around it. Easier said than done when you work in this business. Sometimes we have to go into different situations and we don't have a choice. So we make the best of it and we take the whatever things that we can do to mitigate the risk, but you're never going to be in a completely 100% safe situation. The armed patient. Unless you're law enforcement, it is not our role in the EMS world to be dealing with people that are armed. If we're told that we're responding to a scene and somebody there has a gun, we're parked a couple blocks away. We're letting law enforcement go in there and do their job, and then we'll come in and do our job when it's safe. If you are at the scene of someone who is armed, do your best to immediately withdraw from the scene. This is why, as I said, always leave an escape route for you. And if you're not sure if the scene is safe, don't enter it. Always have law enforcement with you if possible. All right, let's change gears now a little bit. What do you do when you're at the scene and someone's acting goofy and potentially has a behavioral health disorder, but they don't want to go to the hospital? Well, this can be a little troublesome. Maybe they've got some drugs on board and they're acting goofy. Maybe they're alert and they can tell you where they are, but they're slurring their speech, and maybe they don't know what month it is, so they're technically altered. But they don't want to go to the hospital. It's easy if you're talking to somebody and they agree to go to the hospital. Well, then you don't have to worry about any of that. It's this patient here that's refusing to go with you. If you have a belief that this person would do harm to themselves or harm to others in their current state, meaning by them not getting medical treatment, they could potentially be harming themselves, then you're probably going to have to provide care against the patient's will. Now, I'm not advocating for you to strap the person down and take them to the hospital. What I am saying to do is that if you're going to need to take someone to the hospital against their will, it's always best to have law enforcement there to help you to make sure everything that you're doing is legal and safe for the patient. If you are required to restrain a patient, you should consider the following factors: the patient's size and apparent strength, their gender, the type of abnormal behavior, the patient's mental state, and the method of restraint. There have been many documented cases over the years in EMS where patients were restrained inappropriately, and several of those cases ended in patient death. If you're not trained in restraining people appropriately, get someone there who is, typically law enforcement. Now, if someone is violent against you, by all means, you should use reasonable force to defend yourself against an attacker. This is why we have radios, though. If you're getting attacked, do your best to push your safety button on your radio or call for law enforcement right away. But in the meantime, you are certainly allowed to defend yourself. When that's done, you document the conditions that happen and whatever took place. And then, whenever possible, a caregiver of the same sex should take primary responsibility for the care of the patient. There are times where you might respond to the scene of an attempted suicide. Many patients who fail at their first attempt will try to commit suicide again. Statistically, men have a higher success rate of suicide than women do, simply because they choose a more violent method for the suicide most of the time. If there's an underlying psychiatric illness, which there is, generally if they're trying to attempt to hurt themselves, most of those things are treatable. And so we should encourage the patient to come to the hospital and get treated. So the management of these patients, number one, is protect yourself and protect the patient from further harm. Get a good history from the incident and get as much detail as you possibly can, and determine whether the patient still has a weapon or any drugs on him or her. If the patient has already ingested a substance or has already done maneuvers to harm themselves, well, then you want to assess and support the ABCs. Dress any open wounds that you come in contact with, and treat the patient for spinal injuries if you suspect that there could be a spinal cord injury. Remember not to judge. We don't know what's going on in their lives. Our job there is to just support them. Treat the patient for injuries or other conditions that you find and provide emotional support. In today's society, we are seeing more and more documented cases of post-traumatic stress disorder. This can affect anybody, and they don't have to actually experience the trauma themselves in order to classify for having post-traumatic stress. For instance, people in 9/11, even though they may not have been directly involved in one of the tower attacks, there are people that were many, many blocks away that still suffered from post-traumatic stress from the events that occurred that day. EMS providers, law enforcement, and firefighters also suffer from post-traumatic stress from all the stuff that we see in our job. So this is a mental health or behavioral condition triggered by experiencing or witnessing a terrifying event. Symptoms of this include intrusive memories of the traumatic event, so intrusive that it interrupts their ability to function in daily life. They avoid places or activities or people that remind them of the event. They tend to have persistent negative feelings in general, and they have abnormal emotional reactions to situations. When you encounter a patient that you suspect has post-traumatic stress disorder, your job is certainly to protect the patient from harm, particularly them harming themselves. Speak with the patient in a positive and supportive way and arrange for the patient to be transported to an appropriate medical facility, typically one that has psychiatric services available. There may be a point in your career as an EMR where you would have to respond to the scene of someone who has been sexually assaulted. This is a traumatic event for them both physically and psychologically. Your job there is going to be to offer a great deal of support and identify and treat any life threats. Remember, your job as the EMR here is not to be an investigator, so be very careful about the questions that you ask of this patient. You should be asking medical-specific questions when dealing with these patients. Your first priority is the medical well-being. Treat injuries and manage life threats. Do not remove clothing except to give medical care, because you do not want to disturb any evidence. Try to convince the patient not to bathe or use the toilet once again, because that will contaminate evidence. Keep the scene and any evidence as undisturbed and intact as possible, and do whatever you can to work with law enforcement to preserve that evidence. Avoid aggressive questioning of the patient, like I said on the previous slide, and treat the patient with as much empathy as possible. As I stated earlier in the presentation, there's going to be many times where you as the EMR will show up at the scene of a person who has died. But also consider the fact that you may also have to take care of a patient who is actively dying as well. You can encounter death in a variety of different ways. They could be natural causes. Someone might have died in their sleep, and family didn't know what to do, so they called 911. It may be an accidental death, such as a traffic accident on a highway, or it could be intentional causes like a suicide. Your job is to do whatever you can to meet the patient's medical needs or the family's needs. Most people are afraid of dying. Your job is going to be to work through your personal feelings about death so that you can overcome them to be able to be a better provider for the patient. Consider the psychological needs of the patient and his or her family. Don't be afraid to touch the patient and make positive statements, but don't give false hope. Your job is to provide comfort any way you can. This could be for the family of the person who died, or it could be for the patient themselves who is actively dying. Many times EMS is called to transport the patient from the home to perhaps hospice, And in a lot of situations where someone's actively dying and they're getting sicker, the family doesn't know what to do when they're scared, so they call 911. And while there's really nothing that we're going to do for them, we do the best that we can to offer whatever support is necessary to help the family and that patient at that moment. As emergency medical responders, we have a tendency sometimes to respond to horrific scenes, mass casualty situations, shootings, death of children, and all these things after a while tend to build up. We've spent a lot of time in this presentation talking about the psychiatric needs of the patient, but we haven't really talked about the psychiatric needs of you. All these things that we see and we deal with on a daily basis have a tendency to build up. And when you encounter a traumatic event or something that is substantial, you might need to go through a critical incident stress debriefing. This is basically a counseling session that is provided by your peers and mental health professionals that have all gone through specialty training to provide you with care. So, for instance, if you showed up at a school bus accident and multiple children died, that might bother you quite a bit. And so your boss might request a critical incident stress debriefing at which a team of experts will come out and they will provide counseling to help you get through that traumatic situation. So the signs and symptoms of someone experiencing extreme stress would be things like depression, an inability to sleep, weight changes, and increased alcohol consumption or drug use. This is not necessarily patient-specific. This is you and your partner. In addition, other signs and symptoms could be inability to get along with family and coworkers, and lack of interest in food or sex. If you suspect that you or your partner might be suffering from any one of these symptoms, it's not considered to be cowardly to request a critical incident stress debriefing. It's actually good for you to sit and talk about these things with the appropriate professional. So never be afraid to request one of these teams to come out and speak with you, your partner, and the staff. All right, that pretty much covers up the behavioral health section here. Let's just review some topics. So only a small percentage of the patients that you will treat will be severely mentally disturbed. But almost every patient you care for will be experiencing some degree of mental and emotional crisis. And that's very true. Most people only call 911 once in their entire life. And while for us, it's a very common procedure sometimes to see someone with chest pain or for someone with a traumatic injury, for that patient and that family, this is potentially the worst thing that's ever happened to them. And while it's routine for us, we need to take into consideration sometimes how this is affecting the patients, not only medically, but emotionally as well. Behavioral emergencies are situations in which people exhibit abnormal, unacceptable behavior that cannot be tolerated by the patients themselves or by friends, family, or the community. Remember, we kind of come up with the definition of mental health disorders or behavioral health disorders as things that don't fit within our society norms of what we would deem to be normal behavior. Earlier on, we talked about things like psychosis. Psychosis, someone's experiencing delusions and hallucinations. That's not normal. The only caveat I give to you on this one is remember, cultural differences and accepted cultural practices can cause what you and I might think is abnormal behavior. But if it is acceptable behavior in one's culture, it's not considered a behavioral health issue. Recall that there are 5 factors that cause a behavioral crisis: medical conditions, physical trauma conditions, psychiatric illnesses, mind-altering substances, and situational stresses, all of which we've talked about in this presentation. The 4 emotional phases to each crisis are high anxiety or emotional shock, denial, anger, and remorse or grief. Remember that your role as the EMR consists of assessing the patient and providing physical and emotional care. Your most important assessment skill may be your ability to communicate with the patient. If a patient who appears to be disturbed refuses to accept treatment, you may have to provide care against the patient's will. If that happens, it's always best to have law enforcement there with you to assist you in the restraining of patients as well as making sure you're not violating any legal issues. All right, everybody, that sums up the presentation for behavioral health issues as related to the emergency medical responder. I certainly hope you enjoyed this and found this helpful. If you have any questions at all, you can always feel free to reach out to me. Thank you so much and have a wonderful day.